5 more seconds. Okay, so 83% of you guys said tuber infundibular. Very good. So, in terms of the pathophysiology of the disease, the tuber infundibular pathway doesn't have so much of an effect when we're talking about what we normally would see in schizophrenia, but it's dealing with more of how we treat it. So one of the problems as we're going through this is that when we're using drugs that are going to block dopamine, so in the mesolimbic pathway, we're decreasing the dopamine levels, hopefully to resolve the delusions and hallucinations. The problem with the drugs is that they're not going to block dopamine just in the mesolimbic pathway. They're going to block it in the others as well. So the nigrostriatal area, that deals with motor function. It's particularly if you're going to block dopamine in those areas, why you're going to see extrapyramidal symptoms that resemble Parkinson's-like symptoms, okay? So if you're blocking in the mesolimbic, which is what we want, you're blocking psychosis and hallucinations. Mesocortical is the area that we normally think of when we're thinking of cognition, okay? So when I mentioned to you the 3 areas of presenting symptoms of schizophrenia, positive, negative, and cognitive, unfortunately, the disease itself presents some cognitive issues, and then our drugs, because they're going to block dopamine too, are going to add to that. So that's something that we want to make sure we're trying to deal with as well, and it can be problematic because the cognitive issues that are going to present in schizophrenia are one of the biggest barriers to reacclimating patients back into society so they can function, okay? The tuber infundibular pathway, when you block that, normally that naturally would happen in females postpartum when they're lactating, that area basically is going to get suppressed, and that's why you get lactation. So the patient's taking these drugs, what do you think is going to happen? Gynecomastia, let's say your breast enlargement, okay? And you can even have lactation. It's obviously going to probably not be the greatest thing in terms of sex drive. It's going to decrease libido and sex drive, okay? And that kind of makes sense. So we want to target that mesolimbic area, but unfortunately the other pathways that are involved are going to be something we have to deal with in terms of side effects and potentially actually worsening the schizophrenic symptoms in the cognitive pathway. Great. So going through these dopamine pathways a little bit more, I'll make sure you guys are understanding. Again, you can kind of see the substantia nigra area here in terms of the nigrostriatal pathway. Again, we typically see when we're looking at our Parkinson's patients and our drugs that block D2. So dopamine 2 is the receptor that's heavily involved in, you have to have activity on D2 receptors to work as an antipsychotic, okay? So unfortunately, the one that we want to see effect in B here, you're going from the substantia nigra area into the striatum as well in terms of the mesolimbic area, that we want to block dopamine there, that's going to be, problematic because of all the other pathways, as I said already. So when you're thinking of the 4 dopaminergic tracks of what we normally are going to think of, or what we're primarily interested in, nigrostriatal, you're going to remember it deals specifically with movement. Okay. The mesolimbic is what's going to be associated with excess levels. You're going to see psychosis and hallucinations. The mesocortical area, you can hold to cognition. The disease itself, the schizophrenia is going to basically impair cognition, and then our drugs, when they block it into that area, are going to make it even more difficult to treat that. And the tuber infundibular, again, anything that's blocking dopamine in that pathway is going to increase prolactin. So when we're talking about our typical antipsychotics, and some of the newer ones actually as well, for example, Risperdal, it has a little bit stronger D2 binding properties than the other ones. You'll see a higher incidence of increased prolactin in those patients that are taking that. Okay? Now getting into the phases of schizophrenia. We have our prodrome, active, and residual phase. Basically what the prodrome phase is that you're going to start seeing the patient deteriorate. This is the period before the active phase. Okay? So the patient might be getting disorganized, might not be completely in the active phase where you're going to start seeing the delusions and the psychosis, the hallucinations going on. But they're kind of in that phase where they're starting to have everything fall apart. Okay? The active phase is what you would typically think of as when you're going to start presenting with an acute episode. So that is, again, when you're going to have your delusions, your hallucinations, the patient's going to be actively psychotic. You're going to see a lot of those positive symptoms. Those are positive symptoms. And then the negative symptoms associated with that. So the negative symptoms would be like your affect flattening, abolition, those 4A's that we were talking about at the beginning. That are associated with that. And then the residual phase. Some classifications look at the residual phase as just a point where they're not actively psychotic, but it's really when you're going to look at a patient that's overall stabilized on therapy. They may still have some cognitive issues going on, but they're not actively delusional or hallucinating or psychotic or having major positive symptoms. Okay? So that's the 3 phases. Are there any questions on that? We're going to go over that again when we go through the diagnosis stuff. So, yeah. But again, just as long as you're remembering the positive and negative symptoms that are going to be presented in an acute case, is what you got to remember in the acute phase. The clinical presentation of an acute episode is kind of what you would think of, again, in the active phase. So the positive and negative symptoms are going to be going on, and then the residual features, which is going to kind of go along with the residual phase, is after you have the patient treated and on therapy. And when we're going to talk about the importance of making sure that in the residual phase, the patient is aware of what's going on in terms of their disease management, that's going to be huge when we're talking about our non-compliance issues and making sure that we're following up with those cognitive impairments that are going to happen, not only because of the disease, but also because of the medications we're treating with. Okay? So, they're kind of somewhat self-explanatory when we're talking about the clinical presentation side of it. Again, each psychotic episode is thought to cause disease progression. So we're going to want to make sure when we're talking about therapy that we're always recommending therapy in these patients. Psychopharmacology agents are going to be the mainstay of treatment. Now, it's not to say when we talk about the non-pharmacologic therapies that they're not important, especially when we're talking about the cognitive side of things, because, again, that's going to be the biggest barrier for getting patients back into society and getting them activated and having a normal lifestyle and getting them reacclimated to everything. But, again, that's something that we're going to have to manage on a longer-term basis, okay? Most deterioration of psychosocial functioning is going to happen within the first 5 years of onset, which is also part of the reason when the diagnosis is made, it's so important to make sure we're managing it as much as possible and we're preventing that disease progression from happening early on. If you're having a patient that's not getting treated well and they're having episode after episode, I can tell you in the psych department, we see some patients that come in like they're rolling the door because they're not being compassionate care. Their therapy's just not working for them. And you can see their progressive disease quite quickly. So really, really important to make sure you're trying to address that. So when we're looking at the diagnostic symptoms, okay, hallucinations, delusions, disorganized speech, okay, is a common one that you'll see patients are just not making sense. They might have tangential thinking where they're going from one topic to another, or they may just not be able to speak verbally at all, or they'll have a lack of ability to get their point across because they're just all over the place. They're having racing, I won't want to say racing thoughts, which is something you'll see more so in, say, manic patients, but nothing is quite connecting from one topic to the next, okay? These are behaviors, so behavior disturbances that can be disorganized or catatonic. That actually will fall into some of the classifications of schizophrenia when we're talking about our different subtypes, okay? Illusions and positive formal thought disorders. So when you're looking at, the DSM is going to break these down a little bit more to help you guys understand that. But typically, it's the symptoms that we look at as the patient is obviously having, psychosis, delusions going on. It's a little easier to hone in on those positive symptoms. And in terms of our therapy, just to kind of give you a heads up, that all of our typical antipsychotics are known to treat positive symptoms. We're not going to treat the negative symptoms so much. Okay, that's somewhat what our atypicals can do, but across the board, they're all going to have to hit that D2 receptor, which is primarily going to work on improving the positive symptoms when we're talking about therapy. Okay? So positive symptoms overall is basically, when we're talking about therapy, all of our medications that we're going to use in terms of antipsychotics are going to work on D2 receptor. Our older antipsychotics specifically are going to treat only positive symptoms for the most part. How you can remember the difference. Whereas our newer therapies, like our atypical antipsychotics, are going to work on both. So that can help you distinguish, especially if you have a patient coming in and you just want to get them stabilized on choosing therapy, and we get to that point, we'll go over it a little bit. Okay. The negative symptoms, you get affective flattening, so one thing the patient just has overall their emotions very subdued, might not have many facial expressions that go along with that. Alogia, which means poverty of speech. So an example of that would be if someone asked me, how many children do you have? I'd say, I have 2 children named Paul and Melissa. My daughter is 1, my son is 3. Okay? Versus someone you say, how many children do you have? 2. Okay, what are their names? Paul and Melissa. Oh, how old are they? You have to pry the information out of them. So that's what alogia is. Okay? Poverty of speech. The abolition or apathy. So abolition means lack of motivation, and then apathy is not having the desire to really go out and, again, this is kind of going into the 4 A's, right, that we mentioned already. So not having the desire to want to get anything done, having the motivation to do anything. Anhedonia. So what is hedonia? Hedonism. Pleasure. So anhedonia is the absence of pleasure. So the inability to find pleasure in anything. Okay. And then asociality. So they've got a lack of emotion overall, and you can imagine that in terms of the asociality, it's part of the reason why they probably would become withdrawn. And that all falls under the negative symptoms of schizophrenia. So the negative symptoms, and again, when we're going to go into the cognitive symptoms, are actually those that the patient's going to become withdrawn, and they're going to have the cognitive symptoms, say, inattention, impaired working memory, and impaired executive function going on. But we're typically looking at, we have to control the positive symptoms to even begin to treat these. Because if they're delusional and having hallucinations, we can't even get to the point of looking at what those are. But these are actually the biggest barrier when we're looking at treating the patient overall for why we can't quite get them to, get motivated, why they really could care less if they take therapy or if they even think they have a problem again in the first place. And then the cognitive issues that come in after that, when they are actually looking at, their functional ability, that's going to continuously get impaired as the disease progresses. Okay?
The SANS and SAPS.
Okay, so if you guys were looking from one of your intro to psychology, Dr. Peters, with the evaluation of psych patients, one of the major scales that we look at is the PANS, the positive and negative syndrome scale. Basically, the SAPS and the SANS are the positive and negative syndrome scales broken out for just looking at individuals. So that's just the tools that we're going to look at in terms of diagnosis, the tests that we use to look at where they're at in terms of their positive and negative symptoms that we're going to score. Okay? Any questions? Sorry about that. So yeah, the PANS is the one that you're looking at overall the disease progression in terms of schizophrenia is one of the common scales that we use. You guys remember that. So the DSM criteria, again, you're going to have characteristic symptoms, 2 or more of the following must be present, and each persisting for a significant period for at least a 1-month period. Okay? So if it's less than a month and a patient's having delusions and hallucinations, we might just call it, a psychosis. Overall, it might be, we can't quite say it's schizophrenia until the 1-month period has gone by. Okay? So it's usually classified as a psychotic episode. It's not going to quite grab it along. So the patient will be having 2 or more of the following: delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior and negative symptoms that are present. Okay? And if you have only one criterion of these that is specifically looking at delusions that are bizarre, hallucinations are consistent with like a variety of voices, like patients are hearing several different voices in their head versus say just one, okay, that you only need one criterion to make that diagnosis. So when we're talking about hallucinations, you guys have an idea of what hallucinations are, right? You kind of think of your senses. Hallucinations in terms of your five senses. So we have what? Sight, so visual hallucinations, auditory, sensory, taste, and smell, right? So in most of our patients, the hallucinations are going to be auditory hallucinations. So they're going to be hearing voices. About 10% of schizophrenic patients will have visual hallucinations, but they're much less common. That's usually associated with drug abuse, right? And then olfactory is usually more so cancer-related. Similarly, tactile might be some kind of neuralgia going on or some other issue. Not so much what we would see typical of schizophrenia, okay? And taste. A lot of times taste is associated with, drug exposures. A lot of our, say, when we talk about lithium XP, lithium can have an altered taste, like a metallic taste. So you're primarily going to be thinking of your auditory as being the major one, and then to a little bit lesser degree the visual hallucinations that can happen. Okay? Yes?
If that's more of the active of like the delusions and everything, how long would it take to do, I guess, how long does the program take? Like how long does it take for someone to deteriorate to that point?
It can be happening over a couple months, or it can happen within a couple weeks. Typically, it's usually going on for over the course of a month. We'd say is probably on average the patient will start to deteriorate. But I mean, there's sometimes it's a really good question. So how long does the prodrome phase last? It's really, again, patient specific to a certain degree, but it's usually about a month that you'll start seeing the patient start to become safe. Okay. So the other issue is the social and occupational dysfunction, as you can kind of imagine, going along with the negative symptoms too and the cognitive symptoms too. For a significant portion of time, onset of the disorder, one or more major areas of functioning, so work, interpersonal relations, and self-care are significantly below the level prior to onset. So most of the time, it's going to be in all areas. It's not, say, when we're talking about when we get to ADHD, it's got to be in, two areas, work and school. It's usually across the board that there's going to be major underlying issues, okay? And then duration. So continuous signs of disorder for at least 6 months. So we start thinking about the diagnosis if the symptoms have been present for about 1 month, and we're definitively saying if it's occurring for more than 6 months, that it's diagnostic of schizophrenia overall. So again, making sure you're looking at the overall criteria. But as we kind of just alluded to, the prodrome phase can be about, say 1 month. It could be going over the course of several months until they actually get to the point of having the active phase of hallucinations. All right?
Sure.
Yes.
Just to go back 2 slides.
Sure.
Delusions, can you give an explanation or example of a delusion?
Yes. So delusions are like what we normally think of as fixed false beliefs. So, for example, I had a patient that literally thought that he was Michael Jackson, that he owned an island in West Palm Beach, that, he was actually one of our more fun patients that, he would break out in song in the middle of the unit, and no one could tell him otherwise. He literally thought that he was Michael Jackson. And I know sometimes you look at that and think, okay, that doesn't quite make sense, but you will not, if they get their thought on something specific, there's no changing it. There's no reasoning with it. So that's why they call it fixed false beliefs. Some of that can play into other parts of the disorder, like when we're talking about patients that have the idea that I had a patient I remember that specifically thought that they had a relationship with Condoleezza Rice. And, that called the White House and tried to get a hold of her and literally, like went into, things that had happened when they had met, and so fixed false beliefs. Okay. And then, of course, like everything else, you're going to make sure the disorder is not due to another medical disorder, substance abuse, and that it's not in the history of a phase of developmental disorder. And if there is, there's got to be symptoms of hallucination or delusion present. So there's got to be symptoms present for at least 1 month. Okay? So, as I mentioned, the different subtypes of schizophrenia, there's 5 different subtypes. The most common out of all of them is the paranoid type. When you guys are going to see these abbreviated when you're looking at your accesses 1 through 5, you'll see basically S stands for schizophrenia in the beginning, and then C stands for chronic, and then it'll either be P, D, C, or U. So that's either paranoid, disorganized, catatonic, or undifferentiated type. So SCUT is paranoid or schizophrenic chronic undifferentiated type, or SCPT, again, most common, schizophrenic chronic paranoid type. So kind of like you would expect, paranoid type, the patient often thinks that people are out to get them, has a lot of fear. And if you guys have ever been driving along your way and you go by, say, someone's apartment that the entire thing is covered in tinfoil, you ever seen something like that where you go by and all the windows are like blocked off? There's a good chance that that might be a schizophrenic patient that's paranoid that they're getting, satellite signals or whatever, someone's trying to, contact them, or they're trying to block it out. That's actually, when a lot of the caseworkers I've worked with over the past several years, they'll do home visits specifically to see how the patient's been managing the illness, what brought them in, and where we can send them when we're getting ready to discharge them. And the paranoid type, a lot of the times, there'll be things specifically like that, when you're trying to block out things from the outside world. So they're afraid that someone or something is out to get them a lot of the time. Disorganized type, this is basically where you'll have a lot more of the patients with the tangential thinking. The thought processes are just not connecting from one to the next. Not to say you can't have some overlap overall with when we're going through these, but typically the major presenting symptom is how you're going to nail down the subtype. Catatonic type. So, if you guys have ever thought of like a catatonic patient, basically they're completely out of it. They are going to not have any interaction with the world around them most of the time. So they'll sometimes stop eating, sometimes, will stop going to the bathroom, they're not talking, they're completely mute, which is very characteristic of catatonic. They're almost always going to be mute. And interestingly, when we're talking about our drug therapies, we're going to use antipsychotics, but that's the one time that we'll actually use a benzodiazepine. And you guys learned about that with Dr. Teeter. Remember, one of the side effects is disinhibition. So we actually hope that it'll disinhibit them a lot. And we can use our other drug therapies to start bringing them back out of the catatonic phase. And then undifferentiated type, which doesn't really fall into the other categories and kind of is less of the others. And then residual type, so if they're, when we're talking about the residual type, some people say you can't really have a residual type, you're going to fall into one of these before, but if someone's responding to therapy and their overall functioning, they might still have some residual cognitive impairment or some negative symptoms that are presenting, but overall it's that they've been out of one of the other four and they're not really falling back into that. So it can potentially change if you're looking at residual type. But again, most of the time we're going to stick to one of the four that you see here, paranoid, disorganized, catatonic, undifferentiated. Yes?
Do people ever recover from schizophrenia? Or are they going to be on drug therapy forever?
You can have what is known as schizophreniform episodes, or you can have just episodes of psychosis, and that's kind of like where you're not really looking at schizophrenia as a diagnosis, because remember, that's something that's going to present usually over a 6-month period that you're going to see continuous level of symptoms to make that diagnosis. So the 1 month of progressive deterioration, and then 6 months overall where things are kind of going on. that point, if it resolves, then you would just call that, either part of your psychotic episode or could be leading to the diagnosis of schizophrenia, yes. But when you actually have a second bout of it, chances are you're probably looking at a disorder and you're not usually going to be much recovered from it. Now, that's not to say with drug therapy you can't halt things a little bit and, limit the progression of the disease. And I can tell you, I know of a professor who has schizophrenia. She went to Yale and Oxford. She's brilliant. And she, has talked about her disorder, how, when she was actually at Yale and someone caught her up on the third story of the building, like getting ready to jump. And, she went in and got therapy, and that's happened a couple times in her life where she's gotten to the point where she had to get institutionalized and get remedicated. Now that she's gotten to a point where she's come to terms with the illness and she's on it, she hasn't had an episode in several years. So you can get to that point where you're looking at a residual phase, but if you stop therapy, most of the time you're going to end up cycling back into that, and so it is lifelong condition. Yes.
I know this isn't exactly our topic, but in my high school undergrad psychology, we always learned about personalities, and in the book it doesn't mention them. And I was wondering how you would treat that.
Some people argue that it's not even a legitimate diagnosis, but there has been some people that that's more what would relate to, say, a PTSD thing where patients will shift in and out of like different phases. When we're talking, say, split personality per se, people will often confuse it with bipolar disorder. Not the case. That's actually something very different, and a lot of the times it's relating back more so to a trauma that's occurred, and that's the response that comes out of it. That's really actually, for the actual diagnosis of that, it's pretty darn rare.
Okay.
So,
Good question.
yep.
So do you begin treatment after the 1 month of severe symptoms, or do you wait till the 6 months to make it effective?
When you're in the acute phase, the first thing you're going to do, it doesn't matter whether it's bipolar or a schizophrenic, if they're psychotic, you're going to treat them with an antipsychotic. And then after that, depending on how they respond to therapy, actually, it will cue you on to which diagnosis you're going to be treating. If I have a patient that comes in psychotic that's because of bipolar versus schizophrenia, I can't tell when they first walk through the door if they're actively psychotic. But once you start therapy, their response again, and then their residual issues after that will clue you in a lot more onto what you're actually thinking. Okay? Any other questions? Yeah? Okay. So again, the schizophrenia rating scales, if you guys were looking at that initial evaluation of psychiatric illness in your bureaus, you probably came across these. The most common one that we'll use again for a lot of the schizophrenia scales is the PAN score. Commonly we'll also employ the BPRS, the Brief Psychiatric Rating Scale, and a lot of the times in practice we use BPRS all the time because it incorporates the AIM scale, which is the Abnormal Involuntary Movement Scale. So if we are treating patients with antipsychotics, it kind of helps capture if that's kind of part of the picture of our medications are presenting with that. Okay? And then the CGIs is another one you'll see in terms of the literature that they'll use a lot, that they'll evaluate the Clinical Global Impression Scale, basically as a scale from 1 to 7 that your clinician will determine the level of impairment of either much improved, about the same, or getting worse. Okay, and then the various cognitive scales. So the mini mental status exam specifically is something that we'll use in all the dementias across the board. Generally, we'll employ that. And as the disease progresses in the later stages, you'll see significant impairment on that. If you can get somebody overall early on in therapy, not to say that they'll end up with that specific amount of impairment for the mini mental, but again, when we get to the point of looking at other dementias, you'll see that a little bit more. And then the information, memory, concentration, dementia rating skills, and clock drawing are just other cognitive skills that we can employ. Okay? So let's look at a quick patient case. Base case, an obese 33-year-old white female brought to the ER by police after wandering in traffic on Route 1 twisting her own urine. She states a police officer brought her to the ER so she could collect money for stealing her unborn child. She jumps into bed and becomes hostile towards staff trying to kick the nurse, claiming he now wants to steal her baby. She claims to be 9 months pregnant with Tiger Woods, and this is their third child together. Who knows, that might Toxicology examiner was treating a patient about 1 year ago for injection bottles of trazodone. So another family history guy ended up proving it a little there. Turns you had asked what medication you could recommend to prevent the patient from hurting herself and staff. So this is typically, when I was in the hospital, one of the phone calls I would get saying, what do you think we should do right away in this patient? And you can't answer those a lot of the times when they come out without getting somewhat of a history in these type of patients, really looking at the medical workup, finding out what else has been going on. So what additional information would you like to quickly obtain? As we were looking at this patient, going through, looks like she's already been admitted once before, so maybe seeing if there was a diagnosis the last time she was here, seeing if her sisters got somewhat of the same diagnosis, if the trazodone worked or didn't work. One of the cues for therapy that's actually kind of nice when we're looking at family history, if there is someone else that has it, unfortunately, is actually one of the positive things is say the trazodone works in the sister, a lot of the times it'll work in your patient. I remember several times throughout the years when we have actually had those cases of family coming in. I remember working at the VA one day, and this guy finally brought his brother in who had been presenting with symptoms, and they were trying to, ignore the fact that he was developing the disorder. And we went through med after med after med, and finally, when he got referred to me for consult, I said, okay, we know his brother has it. Why aren't we looking at what his brother's been treating with? Instantly, we switched him to risperidol, and it's the first thing that worked. So that can be real important if you do have that type of a history. Okay? What labs, tests, or other procedures would you like ordered for HK? So basically, this is ruling out other etiologies. And then, is there something that's causing an exacerbation? I can tell you when I was working in the adult units that I would say of my elderly females, say 60 or older, that 1 in 4, maybe 1 in 3 even, of the times that they would get admitted to the unit, they would have a UTI. For whatever reason, when they would have a UTI, it causes some secondary issue with a glucose abnormality in the brain, and it triggers psychosis for whatever reason in those patients. So I would make sure, especially if somebody was coming in, that we would just do a simple urinalysis and make sure they didn't have a UTI going on that could cause the symptom exacerbation. That's not to say you wouldn't obviously treat for that symptom exacerbation, but you're also going to be giving antibiotics and will resolve the issue a lot quicker. Okay? So again, complete history, kind of breaking that all down. Doing a full physical and neuro exam, making sure that you're ruling out any other secondary etiologies with the labs that you see listed there, and doing the mental status exam with every psych patient that would come in. Okay? Make sure, as pharmacists, this is a big one, right? Make sure we're not having any other drugs or diseases that can cause psychosis. So corticosteroids, very well known. Similarly, when I'm talking about glucose abnormalities that happen in the brain, corticosteroids are known to have that shift kind of occur and induce psychosis. Okay? Stimulants, as you think about what those drugs actually do, they're increasing dopamine levels. Anything that's going to increase dopamine levels can potentially cause psychosis, right? So especially in patients that are, say, abusing cocaine, they're going to come in psychotic. A lot of the times the drug wears off and the psychosis goes away. Make sure you're not confusing that. And again, if you have somebody who's schizophrenic and using it, and sometimes it will actually induce them into an acute phase of the disorder. Dopamine augmenting agents. So I've actually had patients that will, have schizophrenia, and for whatever reason, they develop restless-leg syndrome. One of the big marketing ploys over the last couple of years with drugs that were used to treat Parkinson's, they re-put in Mirapex, those dopamine augmenting agents, specifically, increase dopamine. You get somebody who's schizophrenic that maybe they go to see their PCP that's not paying attention, you put them on one of those, and they're going to end up getting psychotic because it's going to increase dopamine levels. Okay, so make sure you're watching out for that. Or just even in Parkinson's patients that might get put on them, or for those that have RLS, making sure that's not using it. Hallucinogens, obviously, well, gas and toxicity is another one. And then looking at other diseases. So, especially in the advanced stages of AIDS, there's AIDS-type dementias, central nervous system diseases. I can tell you in my epileptic patients that when we're looking at the comorbidity of psych disorders and epilepsy, it's extremely high. okay, and making sure that if the patient's necessarily having epilepsy, as you can imagine, there's some neuronal circuitry that's kind of going haywire there. That in some patients can induce a psychosis, and you don't want to necessarily mistake a seizure that has. We have had patients that have been mistaken for psychosis when they actually had seizure disorder. Head trauma, cardiovascular accidents, infections. Especially with infections, underlying infections, again, they can cause that glucose abnormality in the brain and trigger it. Specifically neurosyphilis. When you guys get into your ID portion, you might learn a little more about that. But tertiary syphilis, so not the beginning stages of the disease, but for example, if you have somebody that has syphilis and the initial symptoms kind of go away, the disease lies dormant, you get into, say, 20, 30, sometimes 40 years after the initial exposure, and all of a sudden the patient becomes psychotic. Well, basically that's because the parasite wasn't treated and it made Swiss cheese of the brain. Okay, so making sure that you're basically doing a simple syphilis test and ruling that out. And then patients that have Huntington's disease have been known in the later stages to present similar to schizophrenic patients with psychosis, and actually water intoxication. Someone consuming large amounts, like you've ever seen patients. Have you ever heard of somebody who's gone through hazing and fraternity? I remember a couple of years back there was a kid that died. Water intoxication doesn't do good things. Too much of anything that's actually good for you is bad, right? So that's actually infusing. And it's kind of interesting because those schizophrenic patients actually get polydipsia, which is increasing water and they'll like constantly drink. And that might actually be a trigger for nice psychosis.
At what kind of doses does caffeine cause it?
More so you'll see it in those patients that are, say, abusing caffeine tablets. Not to say that if you have someone who's schizophrenic that it could trigger it if they were like all of a sudden going from somebody that didn't drink it to someone who was drinking 5 Red Bulls a day. But I know I get I always get a question when I mention caffeine because who hears in pharmacy school don't drink caffeine? Is there anybody? Who's from you? Okay. So, non-pharmacologic therapy, again, when you guys are thinking of therapy, pharmacotherapy is the mainstay of treatment, all right? But when we're dealing with the negative symptoms and the cognitive symptoms, we're definitely going to employ our non-pharmacologic therapy to treat that. You can kind of go through what all those are without me reading them. It makes sense. You're going to have to treat the whole patient to see a full beneficial effect in the treatment of these patients. The plan is going to be developed that it delineates drug-related aspects of therapy, meaning like you're going to look at target symptoms. So if I have a patient that's specifically, having a lot of negative symptoms, I might lean more towards one drug over another, and we'll go through that when we're selecting our pharmacotherapy. And expected response time, previous or family history again, side effect profiles. A lot of the time I'm just picking medications that are in line with not exacerbating another medical disorder or other even psych issues that are going on. And we'll talk about that a lot more. Drug interactions, so looking at those pharmacodynamic and pharmacokinetic issues. For example, in patients who are taking Zyprexa and smoke, it actually will decrease the clearance of the drug by 50%. Okay? So, number one, a huge population of our schizophrenics smoke. Huge. Okay? It's usually, in looking at a lot of the studies, I've never seen anything less than 40%. I've seen up to 85%, okay, in some studies. So if you have somebody that actually stops smoking and they're taking Zyprexa, it can help with drug levels. Or conversely, they're taking Zyprexa and they decide they're going to start smoking again, it's going to cut it in half and you might end up with somebody getting psychotic on top of that. All right, so that's real important, paying attention to that type of interaction. A lot of these patients are going to be indigent. They're not going to be taking care of themselves. They're going to end up making sure that we're having them treated for something they can afford. And we're looking at some of these atypical drugs that are really expensive. And without getting them sometimes on some of those patient assistance programs, they may not be able to pay for the medications, which leads into more of the issue of compliance that we talked about. Okay? We want to avoid polypharmacy whenever possible. In our treatment-resistant patients, that might be a little different. But in terms of, especially when we're initiating therapy and in the earlier phase of the disease, study after study after study has shown that polypharmacy does not improve patient care. So one drug is just as effective as sometimes 2, 3, or 4 drugs that you'll see patients put on. And a lot of the time when you're increasing the pill burden, not only are you dealing with compliance issues, but you're also dealing with so many more side effects that can actually exacerbate some of the other issues with schizophrenia. Say I have somebody who's on, for example, our atypical and Abilify, and then Haldol, a typical. Does that make sense? Why would I give somebody a typical that I have to worry about all those extrapyramidal side effects that we're going to talk about? And, if they're going to be on Abilify, which is the whole point of that, and then you're throwing other metabolic issues on top of that. Okay, so trying to make sense of it all. All right, so when we're looking at our responsiveness to medication, if you have somebody coming in who's actively psychotic, you want to make sure that you're going to treat them with something that's going to deal directly with that. So sometimes you might target somebody with, nothing has ever been proven more effective than the older drugs. So in terms of positive symptoms, okay, the newer therapies are as efficacious or about as efficacious as those. So I might, initially treat somebody with Haldol, but then longer term be looking at not putting them on that type of drug because of the side effects it causes. But any of the ones that you're going to pick, if you're giving them medication and they're going to be responsive, within 1 to 2 days, you're going to see a decrease in their hyperactivity, badness, hostility, agitation, aggression, and anxiety overall. Okay? When we're talking about really starting to see some improvement in some of the other positive symptoms like our hallucinations, it's usually going to take 1 to 2 weeks. So if you have somebody coming in that's truly, in the acute active phase and they're psychotic, it's going to usually take at least a minimum of 7 days to truly pull them out of having those hallucinations. There's going to be improvement hopefully at that point in sleep as well, appetite, hygiene. We can usually tell when patients are doing better because when they're having hallucinations, delusions, do you actually think they're going to take care of themselves too well? Probably not, right? So hygiene usually is the first thing to go out the window when that starts happening. So when that starts improving, you can kind of tell that the drugs might be having some efficacy as well. And then the delusions and social skills. Are they able to start communicating with other people appropriately? Within 1 to 2 months is when we start hoping that some of the negative symptom improvement and cognitive issues may have a potential to start getting some work done there. And again, that's 1 to 2 months. Not meaning that we're going to keep somebody hospitalized that long, but that's one of those things that in terms of the outpatient management we're going to focus a lot on. And then relapse. So relapse is huge in these patients. Now, looking overall, in a patient that doesn't take therapy, it's about 75% of those patients that are going to end up having relapse. Okay? So studies look at about 60 to 80% will have relapse on placebo, but overall the average number that's usually pronounced is about 75%. That's really high. Okay? 10 to 20% are going to relapse with atypical medications, and that's overall looking at a 20% relapse rate per year of those patients that are or are not, or depending on whatever therapy they're on, it's about 20%, so 1 in 5. And then as the years go on, that goes up actually. So again, making sure we're treating them appropriately and treating them hard and early on. Okay? When we're looking at, again, please remember antipsychotics are the primary treatment modality. You're not doing anybody who's having psychosis any favors by not giving them medication therapy. It's not one of those that we're going to play around with because the longer it goes on, the more damage that we're assuming is going on in the brain. Okay? So again, they're the primary treatment modality. When we're talking about antipsychotics in general, the old terms that used to be used are neuroleptics or major tranquilizers, where we try and talk about it a little bit more in terms of our 2 types, in terms of typical and atypical, a little bit more than we used to in the past. But if you hear it referred to as neuroleptics, that's appropriate to just think of it as an antipsychotic. Okay? And then our typical antipsychotics, as I mentioned, proposed mechanism of action is, again, remember, all antipsychotics have to block D2. But the primary mechanism of action of most of our typicals is they're blocking D1 and D2. Okay? D1 and D2. And then they may also block other receptors, and we'll get into how you guys can easily remember that. But the dirtier the drug, the more anticholinergic side effects you'll have. So those are the ones that are going to be more of your, let's say, chlorpromazine, that are lower potency, versus your higher potency like Haldol is going to be much more specific to D2. and you'll see more EPS. And we'll go over that again to make sure you guys understand that well. And making sure that if we are using a typical, it's primarily looking at treating positive symptoms. A lot of the times, again, if the patient's psychotic, it's going to be something that we'll look at is we know it's going to have a good level of efficacy. Doesn't matter which one you pick, whether it's high potency, low potency, or in between, they're all looked at as equal. It's just kind of looking at side effects. Sometimes one will work better than another in particular patients on why you're going to pick them, okay? And then looking at, basically their half-life kinetics, MOAs, their absorption, whether it's, similar or if there's a couple that are the outliers there on why, again, you're going to pick one over another. A lot of the times, even if it has a long half-life, we're still going to break it up to dose it BID or CID to decrease side effects, because as you guys probably remember from some of the stuff we've learned with PK, when do you typically see side effects? What do you think? You see it at the peak or the trough? Peak, right? So the higher level of the drug in the body is when you're going to see it. So if you can decrease the peak and spread out the dose a little bit more, that'll usually help. You kind of keep that in mind, okay? And when we're talking about the differences among the potency, side effect profiles, so the high potency, again, ones are going to be higher for causing EPS, so that's like your Haldol, your Prolixin. And then our lower potency is going to have higher anticholinergic effects. So that's like our Thorazine or Thyroidine, and those that have got a lot more anticholinergic effects are going to be the lower potency. And then when we talk about dosing, looking at single versus multiple versus compliance and side effects, that's gonna play into the picture overall as well. So, main thing, I'm gonna wrap up with this slide here. The main thing that you're gonna think of when you're thinking of any time you're using a typical drug is the big issue of extrapyramidal side effects. Okay, so EPS are those abnormal motor movements that a lot of the time they're going to resemble similar to a Parkinson's patient's presentation. A third of patients are going to develop EPS on a typical antipsychotic. Now, that does mean 2/3 aren't, but you don't know which those are. And if it does develop, especially if it's not recognized, the big fear is that it's going to turn into what we'll talk about next time is tardive dyskinesia, which is irreversible motor movements that we can't fix at that point. So you've got acute dystonias, which are painful contractions in the muscles, okay, and up to 64% of patients without prophylaxis that get, say, an IM Haldol, okay, that if they're not pre-treated with, say, one of our anticholinergic medications like Cogentin or Artane, Triaxpenadil, or even Benadryl, and those are common ones, diphenhydramine. That they will actually, in terms of, especially your more low potency ones, or your high potency ones like your Haldol and your Prolixin, okay, that you'll end up seeing things like acute dystonia. So the pseudoparkinsonisms, as we talked about, and we'll talk a little bit more about akathisias and treatments next time. But keep in mind, typical drugs, you're worried about EPS. When we get to atypical drugs, you're going to think of metabolic syndrome, okay? So you guys have learned about metabolic syndrome in the past, right? Do you remember any criteria for what metabolic syndrome is? There's 5 criteria. So we'll talk about it more next time. We'll talk about it more next time, but it's basically increases in blood pressure, increases in blood sugar, increases in cholesterol, and increases in weight. And then there's 5 criteria to break that down. So our older drugs will cause EPS, but our newer drugs will end up usually causing cardiovascular complications long term, and those can actually kill you. So, kind of like chicken and egg when we get to that point. All right, so this is where we'll pick up for tomorrow.